Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Next question. This may sound easier in some ways than it actually is. What is the cause of acoustic enhancement on ultrasound? We all know what acoustic enhancement is. We see it every time we read ultrasound scans and we see a cyst. But what causes this? Can you recall? Acoustic enhancement results when the ultrasound beam passes through structures that transmit the sound better than the surrounding tissues, such as simple cysts on a breast ultrasound or the distended gallbladder on a right upper quadrant ultrasound. Another way to say this is that acoustic enhancement occurs when there is less attenuation of the ultrasound beam in fluid-filled structures compared to the surrounding solid tissues and fat. Why this then appears brighter is because of time gain compensation. I hope you already know what time gain compensation is, but if not, the purpose of time gain compensation is to account for attenuation by making deeper structures in the ultrasound image brighter. Without time gain compensation, structures closer to the skin surface would appear brighter because there has been less attenuation, and as the ultrasound system images deeper structures would then appear darker. What we prefer to see is an image that has uniform brightness throughout, and the way to do this is with time gain compensation, where you tell the system to artificially make the deeper structures brighter and the more superficial structures not as bright. So when you have this time gain compensation feature on, and then you encounter tissues that transmit the ultrasound beam better than the tissues surrounding them, the time gain compensation will overcompensate and cause the deeper structures behind the fluid-filled structure to be presented as brighter on the image compared to the other structures that have more attenuation surrounding them. Since there's less attenuation through the fluid-filled structure compared to the tissues surrounding the fluid-filled structure, the fluid-filled structures appear brighter posteriorly, and this results from having uniform time gain compensation applied throughout the image, but a lack of uniformity in terms of the intrinsic attenuation of these structures being imaged. Does that make sense? I certainly hope so. If not, shoot me an email and I can try to discuss this further. Next, what is the cause of acoustic shadowing on ultrasound? Acoustic shadowing results when you have structures such as calcified masses, dense calcifications, or perhaps malignancies with many dense irregular surfaces and interfaces that absorb and or reflect the ultrasound sound waves, thereby leaving a void of signal behind the structure which looks like a shadow. And we therefore call this acoustic shadowing. Next, what is the twinkle artifact and what is this characteristic of? Twinkle artifacts result when imaging with color Doppler imaging and you see the appearance of alternating colors within a highly refractive object such as a calculus. Normally, alternating colors with color Doppler imaging would be typical of turbulent blood flow, but with comet tail artifact, you see the alternating colors that appear on a highly reflective object such as a calculus. On board exams, twinkle artifact would be most classic for something like renal stones. And you can use twinkle artifact to your advantage when you see a highly echogenic structure that you think might represent a stone or calculus. You turn on the color Doppler imaging, you see it twinkle, and this adds support that it is in fact something like a renal stone and not an echogenic mass. Next, what is the cause of a side lobe artifact? This one's a little harder to explain, but I'll try my best. What is the cause of a side lobe artifact? We assume that ultrasound beams leave the transducer almost in a straight, uniform line that spreads out from the transducer, but in reality, you have the primary beam, which does proceed essentially straight out from the ultrasound probe, but you also can have secondary beams that surround the primary beam that come off the transducer in a radial pattern. And if these secondary beams or these quote-unquote side lobe beams that come out of the ultrasound transducer in a radial pattern happen to get reflected back to the transducer, you can see what we term a side lobe artifact. And a side lobe artifact typically appears as a slightly echogenic and curvilinear structure. Look this up to see examples of how side lobe artifact can manifest on images. Conceptually, what is important to understand is that the majority of ultrasound waves come out in the primary beam, but you also have these secondary waves that come out of the transducer in a radial pattern, and if they happen to get reflected back onto the ultrasound probe, it can appear as an echogenic and curvilinear structure on the image, and that is side lobe artifact. Next question. What is anisotropy, and why is this a potential problem for musculoskeletal ultrasound? I just looked up the definition of anisotropy, and I read that anisotropy is the property of substances to exhibit variations in physical properties along different molecular axes. And it is kind of the opposite of isotropic materials. So isotropic materials can be very uniform in all directions, and isotropic structures are not identical in all directions. And for ultrasound, anisotropy can occur if rope-like structures such as a tendon reflect the ultrasound wave away from the transducer. So ultrasound wave enters into the joint, reflects on the tendon away from the transducer, and as a result, the transducer doesn't receive the echo and will make the area look black or hypoechoic, which unfortunately can mimic a tendon tear or other tendon pathology. So anisotropy can be a problem for musculoskeletal ultrasound. To check for this, what you want to do is change the ultrasound angle slightly and then see if the artifact goes away. And tendons typically appear echogenic on the image. So if you see what looks like a tendon tear, but you then change the angle slightly, and suddenly you see an echogenic tendon in what previously looked like a tendon tear, that is an isotropy artifact. How do you prevent color flash artifact? I think we've all probably seen color flash artifact. I see it frequently when I am imaging with ultrasound with color Doppler imaging, and suddenly the patient asks me a question or takes a deep breath. I see flashes of color throughout the screen, and I need to wait until the patient stops talking or stops moving for those color flashes to leave the screen. But what causes this, and how do you prevent it? Color flash artifact results from motion either of tissue that is under the ultrasound beam or also motion of the transducer itself over tissue, and this causes a flash of color when using color Doppler imaging. And a good example of this is flashes of color that you may see on a breast ultrasound when a patient is talking due to movement of the breast and chest tissues from respiration and the vibration from talking. To prevent this artifact, you should take measures to prevent patient motion and also prevent ultrasound probe motion. So when you are imaging with color Doppler imaging, you need to hold the ultrasound probe relatively still, or you will see color flash artifact. Another strategy you should be aware of is that one can reduce the color gain to make the flash artifact less likely to occur. If you crank the color gain up, very small movements of either the patient or the ultrasound probe will cause color flash artifact. If you turn the gain down, your images will be less susceptible to color flash artifact. Next question, true or false? Ultrasound velocity is independent of the frequency of the emitted sound waves. One more time, true or false? Ultrasound velocity is independent of the frequency of the emitted sound waves. This statement is true. The velocity of the sound wave from ultrasound is determined only by the type of material the sound wave is passing through and has nothing to do with the frequency of the emitted sound wave. Ultrasound velocity is calculated as the inverse of the square root of the compressibility of the material. So how compressible a material is determines how fast a sound wave will travel through that material. Less compressible materials have higher sound wave velocities. Therefore, ultrasound waves travel faster through bone and slower through air. Next question. What is acoustic impedance? Acoustic impedance is an intrinsic property of a material that is the product of the density of the material and the velocity of sound within that material. One more time. Acoustic impedance is the property of the density of the material and the velocity of sound within the material. And I just told you that velocity is calculated as the inverse of the square root of the compressibility of the material. So acoustic impedance takes into consideration both density and compressibility, which are both intrinsic properties of a material and have nothing to do with the frequency or wavelength of an ultrasound beam. Differences in acoustic impedance between materials determine how much energy is reflected at the interface of the materials. So interfaces between low acoustic impedance and high acoustic impedance materials will reflect the most energy. Examples of highly reflective interfaces are bone and soft tissue interfaces, as well as soft tissue and air interfaces. Essentially, and this is a key point, an ultrasound image is basically an acoustic impedance map. What we are imaging are differences in acoustic impedance between different material interfaces. So for us as physicians imaging patients, differences between the density and compressibility of soft tissues within a patient is what gives us the acoustic impedance map that allows us to reconstruct an ultrasound image. Next question. What is the difference between non-specular and specular reflections? That is SPECULAR, specular. What is the difference between non-specular and specular reflections? Specular reflections are from large, smooth surfaces, and specular reflections reflect a lot of sound waves back to the transducer. Non-specular reflections are from rough and irregular materials or interfaces that scatter a lot of these sound waves rather than reflecting the sound waves. The echoes from specular reflections are the primary component of ultrasound images. Next question. What does ultrasound gel do to improve the image quality of an ultrasound system? Ultrasound gel displaces air between the ultrasound transducer and the patient's soft tissues, thereby removing air that would otherwise exist between the transducer and the patient's skin. If you had air between the transducer and the patient's skin, this would create a large difference in acoustic impedance, and this would reflect rather than transmit the ultrasound waves. So essentially, the ultrasound waves would reflect before they even enter the patient's body, and to prevent that, we image through gel, which displaces air and allows the ultrasound beam to enter the patient's body. Next question. If a surface being imaged is larger than the wavelength of an ultrasound beam, does this promote reflection or scatter of the ultrasound beam? There are many components there, so let me state this one more time. If a surface being imaged is larger than the wavelength of an ultrasound beam, does this promote reflection or scatter? The answer is that large surfaces promote reflection of the ultrasound beam. In general, if the surface is larger than the wavelength of ultrasound, reflection will occur. If a surface is smaller than the wavelength of ultrasound, scatter will occur. Next, does increased scatter increase or decrease the echogenicity of a structure? The answer is that increases in scatter increase the echogenicity on an image. Echogenicity literally has echo in the name, and this is because the echogenicity is related to the degree of echoes from a tissue. This is why cysts are anechoic, meaning no echoes, because they transmit the ultrasound wave without scatter, and they are therefore anechoic, or another way of saying that is without scatter. So the more scatter you have, the more echogenicity you see on your image. Structures that have no scatter are anechoic, as the name would suggest. Next, what are two major factors that increase attenuation of ultrasound in the body? Can you think of two major factors that cause attenuation? The two factors I have in mind are absorption and scatter. So if you absorb the ultrasound beam or if you scatter the ultrasound beam, both of these contribute to attenuation. Next question. What is the primary determinant of the frequency of an ultrasound probe? As a hint, this has a lot to do with one specific aspect of a crystal. So again, what is the primary determinant of the frequency of an ultrasound probe? The thickness of the piezoelectric crystal determines the frequency. Higher frequency probes are thinner and have thinner crystals, and lower frequency probes are thicker and have wider crystals. To help you remember this, think of the hockey stick probe and remember how thin the hockey stick portion of the hockey stick probe is. Now, hockey stick probes are very high frequency transducers, therefore they require a very thin crystal. In general, smaller frequency probes give more detailed images, such as with the hockey stick probe. The trade-off, however, is that higher frequency probes tend to have worse depth penetration. Final question for this episode. What is the pulse repetition frequency, and how does changing the pulse repetition frequency affect an ultrasound image? The pulse repetition frequency is a measure of how many sound waves are transmitted per unit time. In general, an ultrasound system listens about 100 times longer than it transmits. And the longer you listen, meaning the lower the pulse repetition frequency, the more time the sound wave has to penetrate tissue and reflect back to the probe, thereby obtaining deeper echoes. So lower frequencies and lower pulse repetition frequencies result in increased depth penetration with trade-offs of lower spatial and temporal resolution. So if it is important for you to have high temporal resolution, you need a very high pulse repetition frequency. A trade-off of this is that you will not be able to image as deeply as you would be able to if you had a lower pulse repetition frequency. A lower pulse repetition frequency means that you transmit a sound wave, and then you give that sound wave more time to enter and travel through the tissues, find a surface to reflect from, and return back to the ultrasound probe before you transmit the next ultrasound wave and lose your opportunity to receive the initial echo. Does that make sense? I certainly hope so. I also hope that these episodes on ultrasound artifacts and physics are beneficial for you. Physics in general is a highly tested area on the core exam, and I do not think you can spend too much time studying physics. So give yourself a pat on the back for getting through these episodes and taking the time to review and hopefully learn material that will be helpful for you come examination time. I have made a slight update to my website in which I have indexed the podcast episodes I've released so far by topic so that you can sort through topics and find corresponding podcast episodes. I now have enough episodes out that I have had some requests to help residents narrow down episodes by topic. To access this, simply click on an episode name on my website, theradiologyreview.com. Look at the bottom and you will see some tags. Click on those tags and it will pull up other episodes that have the same tag. I suspect this feature will become more and more useful to you as I release more and more episodes. Thank you again for listening to this podcast. If you appreciate these free radiology podcast reviews, please leave me a 5-star review on Apple Podcasts or on your favorite podcast directory. Remember to study hard. You have to study really hard to pass radiology board examinations. Prepare to succeed. Keep up the good work. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.